Good morning, everyone. So great to see so many people here this morning, and we're going to have a look at this very important issue of prostate cancer from a slightly different perspective. This is a very general talk. It's always good to have a general talk at the opening to the conference, and I can certainly see, looking down through the program, there's going to be a few specifics, so it's good to get some of the basic stuff out of the road. Prostate cancer, since it was first understood many years ago, has always faced a myriad of options in terms of treatments. And, a couple of hundred years ago, these treatments were regarded as cutting edge. They were regarded at the time as being scientific, and yet we look back today as them being pretty risky, with a great deal of quackery, and sometimes downright dangerous. And have no doubt that where we're sitting today, our successors in many years' time will probably look back at a lot of the sort of stuff that we're doing with a great deal of skepticism. So what we're going to have a look at this morning is just a little bit about the history. Now, the reason we go back through history is that we can learn an awful lot from the past, and it's very important that we don't forget those important lessons. We're going to also have a look at about men and what they can expect from some of their treatments. We're going to have a look at options, patient factors, watch out for the surgeon, and a bit of other stuff. So hopefully at the end of the day, we will have some messages that we can look at. And I guess it's a word that we've heard once or twice already this morning. It is just so important that men and their families can become empowered. And everything that Mark said this morning about our difficulties in getting traction with the ministry are absolutely correct. But the other side of the equation is that when you go and front up to your GP, that is the most powerful manner in which you can get traction. You've got to put pressure on. You can't do that unless you have some knowledge. So the reason for such important meetings as this, and for presentations like I'm going to run through here, are just some of those little tricks you can look at in terms of how can I understand a little bit more about this important disease, so when I go and get checked, I know what to look for. So the prostate is an interesting organ, and it was first noted back in 1536. It was a Venetian anatomist by the name of Niccolò Massa who discovered it. So way back in those Greek times with Hippocrates, he didn't know what the prostate was, didn't have a clue. So it is a fairly recent discovery. And even when we look at prostate cancer, it wasn't till a surgeon by the name of Dr. John Adams, he used to work in the London hospital, he discovered it for the first time, and that was way back in 1853 where it was first described. So this is a very recent discovery. And it was regarded as a very rare disease. And if you have a think, well, why did they think this was so rare where these days it is so common? Have a think. There was no PSA, there were no prostate biopsies. The only disease that they encountered was very advanced prostate cancer. And of course, when you look back at the 1850s, the life expectancy for men was very short. So when you think about prostate cancer being a disease of aging males, it is not surprising that it's only in fairly recent times that it's gained the prominence that it has, even though it was discovered many years ago. And when you have a look at the science of the day, that is an honest list of the sort of stuff that they needed to advocate for managing this disease. It was a problem, because prostate cancer was discovered because men got lots of troubles passing urine. It obstructed the urinary tract. They got miserable problems with death from renal failure because their kidneys blocked up. And so you can see the list of stuff that they looked at, even to the extent of putting big probes up into the rectum, into the prostate, and throwing the switch with the hope that by cooking it with the galvanic current, it would do the job. Did it work? Sometimes it did, because they fizzled the stuff with electricity, it burnt the prostate, shrunk it down, and sometimes it did some good. Not too different to what we do with ionizing radiation today. And you give it a couple of hundred years, they'll be looking back at these cranks in 2016 who were delivering this, high beam stuff with lots of complications to patients. So I was going to say watch the space, but none of us are going to be around to see that sort of reaction. And the earliest operations were taken up pretty quickly, and this was a chap by the name of von Dittel, and you can see this is his finger here, which is groping down through his lower abdomen. This is the prostate, and he's enucleating the gland, and this was the first ever deliberate operation for prostate enucleation. And that word deliberate I say quite sincerely, because now and again surgeons tended to wander amongst the blood, poor light and the gloom of the operating theatres of the day, and there were a few accidental prostate removals, but this was the first one. It was an easy operation. The difficulty with it was fraught with danger, with blood loss, with sepsis. Remember, no antibiotics, no blood transfusions, but if it was done well and you survived the procedure, the outcome generally was pretty good because you really did get unblocked and you could pass urine satisfactorily. The more modern approach came with a very, very skilled surgeon by the name of Hugh Hampton Young, and he did the first radical prostatectomy in Johns Hopkins in the US, and this particular medical centre is still famous today for a lot of the really good work that is done in terms of dealing with prostate cancer. And interestingly, he had this very, very skilled development of the operating table. For those at the back, you may struggle a little, but this is a icon here of the man with his perineum facing, legs up in stirrup. And this, of course, is where the word operating theatre came from, and that surgeons from all over the world came to visit him to learn how to do this particular type of removal of the prostate for the cancer. He had retractors that were named after him. This is looking in towards the prostate through the perineum, just in front of the back passage. This is a modern day photo, but the incision is taken from exactly the same sort of procedure. And this way back then was regarded as cutting edge as you possibly can. And it's interesting, isn't it? There were surgeons who also got very involved with radiation as well. And this here is a diagram that Hugh Hampton did way back in 1921-22. This is the prostate, seminal vesicles coming up here. This double-hatched area is where the prostate felt really, really hard and craggy. Up here, these straight hatches were where it just felt a little bit indurated. And he stuck radium needles into the prostate. I'll show you a little diagram about how he did that, because he felt, following the discovery of radiation by Pierre Curie, that if these radium needles could be put into the prostate, maybe it would help the cancer. 10 months down the track, examining the prostate, he could find no abnormality at all, still a little bit of induration of the seminal vesicles, but this was his method of trying to determine whether the treatment was actually working. How did he put them in? He had a brass tube shoved down here into the rectum. He tried to eyeball the prostate, and the long brass probe was put down with the radium needles on the end, and that's how he actually did the implant. Absolute, very clear-cut, cutting-edge stuff at the time. Bagshaw from Stanford, he was the one that got hold of ionizing radiation, and exactly the same method, but more with refined technology these days, is used for treating prostate cancer. The external beam that many of you will be familiar with is pretty much used only for more advanced disease, but this is when it started off back there in 1962 at Stanford. And when we have a look at the operation, the radical prostatectomy that many of you in the room will have had was modified by Patrick Walsh. He didn't actually invent the surgery. It was done by a guy by the name of Terence Millen, who was actually a London urologist, and one of his students went to work with Walsh. Walsh picked it up and ran with it, but this is the time where modern surgery really became available in terms of how to deal with prostates appropriately with surgery. We heard a little bit today about brachytherapy and why it is funded in the private sector, but it's not in the public hospitals. I don't have the answer to that either, I'm afraid. I don't quite know why that is. It's bound to be a funding issue, I would expect. But this guy, Holm, was a surgeon who worked at the Gentofte Hospital in Copenhagen, and he had a real interest in ultrasound. And he started doing rectal ultrasounds and suddenly thought, wow, I'm getting such a good view of the prostate, why can't I use this ultrasound to start putting little radioactive seeds in? And he developed the technique of loading these little radioactive seeds on a wax straw. And that single discovery of being able to put these seeds in so they were evenly distributed through the whole prostate revolutionized brachytherapy treatment. And that really has now also become one of the mainstays of treatment. And it's really interesting for us as urologists and when we look at issues of science, and very, very important for all men and their families, is when you're looking at different treatments. So today we've looked at external beam, which we've got on the table. We have got radical prostatectomy on the table. We have got low dose rate brachytherapy with those little seeds. How on earth do you tell whether one is better than the other or not? Well, what you've got to consider is the power of evidence. And there's a lot of stuff going on out there about this at the moment. And we know that on the basis of the evidence for prostate cancer that is confined to the gland and which is not particularly aggressive, all three of those treatments are equivalent in their cure. But those are the gold standards by which everything else have to work. And if you go and see a practitioner and you're looking at alternate treatment, and we'll have a look briefly at some of those in a few minutes, like cryotherapy or high-frequency focused ultrasound or all this other stuff, the way we look at it as urologists is say, okay, is there any evidence that these new therapies match up against the gold standards that we have? And these are sort of questions you should be able to ask when you go and get checked. Ask for the evidence behind the treatment that is being offered to you. When you go and see your doctor as well, you also need to walk into that room with your own expectations. That is really, really important. You need to go and have a look and see, what am I facing up to? So, cure. Once you've had the treatment, you need to acknowledge to yourself that you will live with a life of uncertainty. And a lot of men, I think, come to see us and they think, wow, we're going to see the urologist and I'm going to have my radical prostatectomy or my radioactive seed implantation. I'm going to be cured. That's the end of it. Well, the answer is no. And the reason we keep checking men on an annual basis, sometimes for a very long time, is that we know there are always risks of treatment failure. Understand the life of uncertainty. The other thing is you need to be going to see your urologist with an expectation that your treatment will have trade-offs. And these involve side effects, some of which can be particularly troublesome. We have issues of incontinence, particularly with radical prostatectomy. We have issues with erectile dysfunction, with all forms of prostate cancer treatment, and we have issues of bowel disturbance, particularly with the radiation therapy options. Understand some of these before you go and seek help. It really does help the conversation. And all of this is easily available, and I know the Prostate Cancer Foundation do an awful lot of work in providing material that can help get your skill level up in terms of dealing with this. Also, with prostate cancer, you know there is going to be impacts on the relationship with your spouse or your partner. There may be impacts on your social participation and also impacts on whether or not you will want to or be able to continue work, particularly if you're unfortunate enough to have bad adverse effects. So understand those expectations, learn about what can and can't happen. It will make your visit to your urologist or your GP a hang of a lot more worthwhile because you'll go in with a little bit of prior knowledge. The other thing that we need to look at is the issue. There are also issues that will affect you as a patient. This is what we call patient factors, okay? So look at your age. Now, if you are 40 years of age and you get prostate cancer, you're going to want to get treated in some way or other because your life expectancy is so long that you aren't going to want to take the risk of probably not doing anything. But then again, if you are 70 years of age or 75 years of age, particularly if you've got other illnesses, you need to be able to weigh up the benefit of having some treatment against the risk of the treatment that may be offered to you. And also be aware of your own well-being. And if you're ever sitting in the room today and you want to know why you need to watch a few things, if you're going to be having surgery or radiation therapy, these are big ticket items. Obesity, Urologists and other surgeons do not like operating on obese patients, and the reason is the complication rates are so much higher. Diabetes can be tricky, so keep your health good. If you're diabetic, keep it under good control. Heart disease, big issue. Anticoagulants, commonly used these days. Why do we have so many men and women on blood thinning products? The answer is the clever cardiologists, and I say that really sincerely because they have revolutionised life expectancy in medicine, put in a whole lot of cardiac stents. So these little cardiac stents that are put in to unblock our coronary arteries, you can't have them unless you're on a blood thinner. Why is that? It's because the blood is clogged up against the artificial plastic that the stents are made of. So these are big issues, okay? And also if you've had pelvic surgery, previous surgery is always tricky as a surgeon to go back in with lots of scar tissue and stuff. So once again, when you front up to your urologist or your GP, you will have things that you should know about with respect to yourself that is certainly going to help the conversation. There are issues of affordability. I'll come back to the example of radioactive seed implantation. It's actually a pretty neat technique. It has the lowest side effect profile of any of the prostate cancer treatments in terms of dealing with early primary disease. But you can't get it in the public hospital, and if you get it done privately, you're going to be looking at about 28 grand for the privilege of having 100 radioactive seeds put into your prostate. And that is not an affordable option for some people, okay? In addition, you'll have a personal preference as to whether you want to have surgery or radiation or whatever, or maybe have a look at active surveillance, which is what more and more and more of us are looking at for some of our patients now. So beware that there are options that are available to you. The other thing, and Steve, Mark and myself need to look at each other honestly with this slide, don't we, Steve? Because Steve and I know, and we don't ever bring this up amongst our colleagues because it gets us into serious hot water, but if you're a patient, you're going to have surgeon factors that we need to look at. And this is really, really important for you to take into account, and the biggest one is experience. If you're flying an aircraft or you're on a commercial aircraft, you want a pilot that's done 5,000 hours in the cockpit through storms, through gentle stuff, through maybe engine failures that he's got through okay. That's what you want, isn't it? Mark my words, that is also what you want out of a surgeon. So when you go and see a guy, don't have any hesitation in asking the very simple question, how many have you done? How many radical prostatectomies have you done in the last year? If you're a seed implanter, how many brachytherapy cases have you done? Volume. Never hesitate to ask. It will serve you well. Be aware also of surgeon bias. If you start getting the words, well, you know, radical prostatectomy is not a very good operation, you're going to get incontinent, you probably become impotent, all the rest of it. Just always sit back and think, wow, are we doing with a little bit of bias here that we need to be aware of? The other thing that faces all of us is the public-private dichotomy. Am I going to see the surgeon who's offering this wonderful new treatment that is only available in the private sector and it's going to cost me 50 grand? Are we having a look at maybe just a little bit of exploitation here? You know, I'm not saying we're getting that in New Zealand, but watch out for it. You know, always ask the question. And in surgery, we have marketing as well, and there are some classic examples in surgery about the new product. You'll all know, for those interested in marketing, if you can come out with a point of difference, it's great, isn't it? You are offering a technique or a procedure that the man next door doesn't. It's put forward as being a better option, so just be a little bit wary of marketing. The other thing that we look at very much in New Zealand now are also the benefits of high volume surgery. So for example, maybe not so much with prostate cancer, but with some of our really big complex kidney cancer cases, where we can get spread of the tumour into the major blood vessels like the inferior vena cava, the tumour extends up towards the heart. You don't want to have that surgery in a small centre. You need to go to a place maybe like Auckland, where there are some expert urologists up there, deal with big volume stuff, and all of us are aware these places exist. It's probably going to head a little bit that way with prostate cancer as well. So just be aware there is benefit with the high volume centres, and also be aware of choice. And if you've got centres that have various options, like you can have a look at the option of radical surgery or external beam or seed implantation, there are benefits to that, because maybe there are differences within yourself that will make you a better option for one treatment than the other. And there are subtle differences that are very, very specific to different people. The final thing about choice is totally to do with the tumour. And sometimes you'll be able to go in with all the expectations in the world, but it's not going to be your decision. And the grade of that tumour, the degree of the aggressiveness, remains the single most important thing in determining what sort of treatment you're going to get. In a few moments, we're going to have a look at some of the newer options that I'm a little bit sceptical about, and I think globally everyone is. They're designed for what we call localised, low-grade disease. Not too aggressive, and definitely not spread. But if your cancer is highly aggressive, or if it's spread beyond the prostate, your treatment options are going to be entirely different to whether that cancer is confined to the gland and fairly low grade or not an aggressive option. So understand about that. Do a little bit of reading about the biology of prostate cancer, and it will certainly put you in good stead if you're going to be checked out. You all know about these, and I'm not going to spend a lot of time, but these are the standard treatments. These are the treatments that have been proven to be of benefit. And in 2011, there was an analysis done by what is called the Cochrane Group. Now, Cochrane analyses are done by a group of expert researchers who look at the global literature. They actually blend all the scientific studies. And if you can get through a Cochrane analysis with flying colours, we can be pretty sure that the answers that come out have got a very good scientific basis. And a Cochrane analysis was done in 2011 looking at radical prostatectomy, radiation therapy, either external beam or brachytherapy, and found that there was no survival difference depending on what treatment you had, which is great, because then it comes down as a patient who's making a choice to have a look at different aspects of the treatment. And a lot of that is to do with the patient factors, it's to do with your personal choice, and a lot of it is to do with the type of adverse effects that you might see. You also see this active surveillance up here, and I know one of my colleagues is going to be talking about this a little later in the day, but I'm not going to spend any time on it. But there is an awful lot of sense in active surveillance. And this is the reason why the ministry and the government are looking at melanoma, they're looking at bowel cancer, and they're looking at breast, and they're not so worried about prostate cancer. And the reason is simple. It is because prostate cancer has a different tumour biology to everything else. And that difference is that men with low-grade prostate cancer may never see a progression of that disease in their lifetime. And that is why active surveillance exists. It means that with appropriate and careful monitoring by an expert, you may live your lifetime with your cancer and it will never ever cause you any bother. Why do we go that way? We go that way because of the potential adverse effects that we can get with all those other curative treatments. So just bear that in mind, okay? That's really important. These are the non-standard ones, and I'm just going to have a quick look at these. Cryotherapy, proton beams, high-frequency focused ultrasound, and focal laser ablation. Well, you can freeze the prostate if you want. So just to get you orientated, okay, penis up here, scrotum. This is a grid with a whole lot of holes in it. We use exactly the same sort of grid for low-dose rate brachytherapy, but instead of radioactive seeds going in here, we've got some temperature probes at the top. These are little needles going in through which liquid nitrogen are put in. And cryotherapy, when it was first started up a few years ago, was really targeted at men who were felt to have some residual disease in their prostate cancer, particularly after radiation therapy. But it's now been marketed as being useful for treating the whole gland. Why am I putting it up there? It's because there is no evidence that this particular procedure yet has been shown to find any survival benefit. So just be a little bit careful, okay? If someone says, why don't we do some cryotherapy? Just be a little bit careful. Proton beam radiation therapy, high energy protons for treating your prostate cancer. not available in many international cities, maybe looking at in New Zealand. Is it going to be of any potential use? Once again, let's get back to the evidence. There is no evidence as yet that proton beam therapy is showing any survival advantage over any other form of treatment. High frequency focused ultrasound. Here's the prostate here. Ultrasound probe in the rectum. It's aiming some high frequency ultrasound at the prostate. Once again, not been shown to be of any particular survival advantage. And when we come down to focal laser ablation, just to get you orientated, this is a magnetic resonance scan of the pelvis. This is the prostate gland here. This is the urinary passage coming down through here. This is a probe, and through the probe we have a laser fibre coming up through here, and this dark area here is the prostate cancer. Prostate cancers appear dark on magnetic resonance scanning because they are dense. They don't have much water in them. Magnetic resonance scanning is all about water, okay? Ordinary cells got lots of water, so it appears very pale on an MRI. Cancers don't have much water, they're very compact, they appear dark. This is what is called an index tumour. It is a man with prostate cancer where this is presumed to be the dominant tumour. The reason for this focal treatment is that by not affecting or not treating the whole prostate, it means that you are minimising the side effects. The risk is that while you may be dealing with the index tumour, who knows what is around here in terms of other microscopic spread. As yet, no proven benefit. So what it means really is that this is not an issue of throwing these new developments out. It is a matter of all of us sitting in the room here being prepared to say, look, let's look critically at this. When you go and see your urologist, ask what it's all about, ask for the evidence, ask for volumes. And so what are the key tricks? What do you need to learn about what to do? Understand the pathology. We heard a bit this morning, is Gleason score still around? Well, of course it is. But it's being replaced by the ISUP grading system. And as we've heard, there's going to be a national roadshow teaching urologists and pathologists about that. Why do we need to do that? It's because not all pathologists are created equal. They need to come up to speed like everyone else. That's the roadshow. Hey, get in quick, understand it as well, all right? Keep up with what these reports are about. Be realistic about what you want out of your treatment. That's really important. We've been through that, okay? Have it really clear in your mind. When you come to have your radical prostatectomy or your brachytherapy, get someone with experience, okay? It is an absolute no-brainer. Ask about volume. It's a simple question and you must get an honest answer. The surgeon is obliged to tell you that, okay? Make sure there is a clear understanding of your medical background, and I think we all get caught out, and I'm sure Steve's the same as me. If you come to see us and you don't tell us that you're on an anticoagulant, and we've asked the question, you've swore black and blue that you're not, but you've got it wrong, that's a big problem, okay? So just understand your own health. It will put you in good stead. At the moment, stick to the mainstream treatments, unless over the next few years we have evidence to show that the more alternate ones that we regard them as at the moment are actually showing a survival benefit. Be well informed about your potential adverse effects. It's really important to know what treatments are about. And remember that if you've got prostate cancer, that no treatment is completely trouble-free. And if you're lucky enough to be part of a high-volume centre, and they've got urologists and radiation therapists, never be scared of asking for a second opinion, either from another urologist or maybe from a radiation therapist. You are entitled to the information. And the one word we need to look at round the table this morning is empowerment. If you are not empowered, you're going to be doing yourself and your family a great disservice. Get out there and learn about it. Most of us are very happy to help with the knowledge that we can, but that is the single biggest message we can leave you with.